Okay, it's 8:02. Good morning. I'm Neil Kelman, president of the Institute for Family Health and chair of Family Medicine and Community Health at Mount Sinai. And it is a great pleasure this morning to introduce Dr. Raymond Teets. Right after residency, I went to a conference on integrative medicine. It was a 2-day conference. It was fascinating, and I never did anything with it after that for many years because I was so shocked that nobody was really concerned about bringing integrative medicine to underserved communities. So it's a real thrill that we are doing this work. And the work at the Institute and at Sinai and the Downtown Residency Program is being led by Dr. Ray Teets. He's a faculty member at Mount Sinai Downtown Residency in Urban Family Medicine. He's assistant professor at the Icahn School of Medicine at Mount Sinai and board certified in integrative medicine and family medicine. He's also the director of both the Integrative Family Medicine Fellowship at the Institute and the residency curriculum on integrative medicine. He currently serves as secretary on the board of directors of the Academic Consortium for Integrative Medicine and Health, and has experience in clinical outcomes research for integrative medicine, and is currently the site principal investigator for an NIH-funded study on acupuncture. His practice provides primary care integrative family medicine within an underserved setting. He has a strong interest in nutrition, herbs and supplements, and mind-body medicine. Interestingly, his background is in philosophy. And so Dr. Teets is also interested in how the medical paradigm can be rethought to improve mind-body medicine, including in situations where patients present with unexplained symptoms. Red?
Thanks, Neil. Just on a personal note, it's just been a real pleasure to have Ray as a colleague, and what he's done in terms of improving the educational experience and training in integrative medicine in the underserved area. And more importantly, doing some important clinical research and taking our organization that much further towards developing evidence base for a lot of the innovative and creative work that you do. As a philosopher, Ray, you always ask the right question. So thanks.
Ray, it's all you.
All right, thanks. Well, that's very kind, guys. And hopefully, in addition to some decent questions, we'll have some decent answers today. I want to build on essentially how Dr. Kalman framed this, in terms of the title, a review of what we do and how come. We had, a former colleague and a friend, Ben Kligler, Dr. Kligler, speak to us, 2 or 3 months ago about all the work that's happening at the VA system. And really, I saw this as a chance to follow up on that and identify, well, what are we doing? Because we're doing it as well. It's a different way than the VA system. So this is our opportunity for me to share both in terms of what we do and then sort of why we do it, which is, of course, referencing evidence as well as what's the advantages. So my objectives, which hopefully aren't too ambitious, is to review basically the activities that we're doing at IFH, clinical, educational, and research. Number 2, just help us all become familiar with evidence for complementary and integrative health modalities, which is the term we're using these days as per NIH for that part of the world, that part of treatment. Become familiar with the ways in which integrative approach can help common primary care conditions. I think there's always sort of an open question, or at least have been historically, of like, well, is this just something that we talk about with patients because patients want it? And I think the answer is emerging, thankfully, as things have matured over the past decade, is no. That's fine. It's good to be patient-centered, but also we're talking about something that is, in a sense, value added, not a Me Too kind of movement. Forgive the term, Me Too is the wrong turn of phrase there, but not a repetitive thing. We're not just repeating conventional medicine. And then the 4th is talk some about the difficulties with an underserved population and access. You can't really do this work without acknowledging that, which in a sense is what I think Dr. Kalman was referring to when he did the integrative conference. To be clear, I will be talking about some supplements, but I don't have any tie to them, no conflict of interest there. And I'm not trying to endorse them, but do want to be clear on, what's in the market so that we know what we're talking about. So ultimately this idea here is, with the intersection of evidence and integrative medicine, is why do it? I mean, I think that's an important question. Well, why talk about this? Why do it? There is obviously a specialty that's called integrative medicine. I'm board certified in integrative medicine. We have a fellowship that's intentionally to teach folks how to do integrative medicine as a specialty. But that's not what this is about. What we're talking about today, hopefully, and what you'll walk away with, is this sense that it can really be good medicine, that it can be medicine that feels organic, all puns intended, fits into family medicine and primary care paradigm, because there's good evidence. It's also a focus on quality of life, which I think sometimes can be lacking in conventional medicine unintentionally, and safety, and because it can help when our conventional medicine cannot. And that's really what those conditions I want to highlight to some degree. At IFH, we're doing clinical ops. We have clinical ops that have integrative medicine. We're doing the research, and we have educational programs. So there's a lot going on that I want to unpack over the hour. And I think also, incidentally, my colleagues announced, if you do have questions, you are welcome to post them whenever, and we'll try to get to them as we go through. If you think about what sort of the integrative medicine physician has evolved into, basically that's someone like myself, still needing to pay attention, obviously, to standards of care. I want a patient-centered approach, which is what family medicine does anyway. So that's just highlighting that. And then the things that are different or new is trying to have an emphasis on lifestyle medicine, feeling comfortable counseling on herbs and supplements, nutrition, etc., and then making referrals when it's reasonable for our complementary and integrative health colleagues, and still clearly informed by evidence. In practice, then, as I said, we really want this integrated as best medicine or good medicine, not as a specialty. And it really, I think its strength is thinking about quality of life. When you have patients who come with chronic pain or mental illness, functional GI stuff, IBS, and also upper respiratory infections, common colds and the like, that's when I think those, and then also chronic diseases. I mean, I think that's the big chunk of modalities that we see a lot, where I think integrative medicine can show its strength. What we'll do is we'll highlight many of these. We won't get to the URI bronchitis cluster, but we'll highlight the others in terms of how it can be helpful practically. Over the years, I've been very lucky to have worked with such a great team, and we have a decent team now, decent in the sense of decent size. I mean, we have people that are doing really cool stuff, and it's been great to work with folks. Aria Nielsen is a very practiced researcher and also ran a fellowship at Beth Israel years ago. Marcia Handel is invaluable in helping us with our IT presence and our internet presence. And Jamie Scher helps me direct the fellowship. You can see a Stephanie Soto Cruz is one of our folks who work in research for us. Bibi Rosenheim works both in the research and the educational side. And Donna Ma is an acupuncture colleague who's been invaluable in helping our clinical operations move through within research, which has become really critical for clinical outcome studies. I also just want to acknowledge folks who maybe aren't on the team per se, although that's a pretty, porous boundary, but just acknowledge how Matt Beyruti, Pamela Devalle, Taya Erdenango, Diane Hauser, and Ariel Jacobs have just been invaluable in helping us through, specifically, most recently, the HEAL trial, which we're in the midst of and has had its share of challenges, but it's going well. And then our research acupuncturists, which I'll talk about later. We also have significant educational programs at IFH. We have the Integrative Medicine and Residency, or it's abbreviated as the IMR, the Downtown Residency. We have dedicated rotations for both the New York City residencies. There's certainly also education happening upstate as well under the tutelage of Dr. Wesley Ho. They also have, I know, an osteopathic dedicated clinic, and they're looking at other osteopathic offerings. And then this year, starting in July, August, we will have not only our newest fellow, Chelsea Ricord, graduating from our downtown residency, but we also have our inaugural fellow from upstate, Carolyn Kwa. So I'm really excited we'll have 2 fellows in the Integrative Medicine Fellowship, and we'll have then the ability to have some more integrative presence upstate as well. And then the last thing I would just want to highlight, so this is our website. I'm a little embarrassed that I'm on the picture. We got to get some more pictures. With Marsha and I will come up with something. But nonetheless, I highlighted only for two reasons. One, because it's a really great website where Marcia Handel has been tireless in helping and having things posted and highlighting achievements within the integrative medicine community at IFH and Mount Sinai. And then also it does have more information on what we have as an interprofessional program in integrative healthcare. Incidentally, that's open to IFH providers at no cost if they're interested. It's a 40-week program running from September to June, and it provides the backbone for our fellowship in terms of didactics, but it is also intended as a standalone integrative educational experience. It runs 3 to 5 at 17th Street. Of course, it's mostly remote presently. So just if that's anything ever interesting to you and you feel like you could find the time for it, let me know. We do have the ability for some ad hoc participation as well, like a la carte, like if you wanted to come just one lecture or what have you. In terms of clinical operations, you know, I think the thing that I was reflecting on, even as I was thinking about this talk, is how as you know, we have folks come into the institution, integrative medicine and primary care is becoming more widespread, even when necessarily they're not going to quote unquote claim it. You know, I can think of 3 colleagues who have just started in the past 3 or 4 years who have significant integrative medicine education and residency and feel comfortable thinking about an integrative approach and integrative modalities. So I think that's the kind of cool thing that's happening as this is becoming more normalized, is it's percolating through. We have integrative medicine consults with our fellows. Jamie Scher does wonderful integrative nutrition out of 17th Street. We have the acupuncture program at 17th Street that I'll talk a little bit later. Dr. Jung, on her return, will be doing her acupuncture again. I don't know if you know, but Dr. Santa Ana is also certified in acupuncture and just has to figure out, I gather, the specifics of how we can make that happen for him. And then prior to COVID, we had significant group care, which I'll claim just because I see that as part of the ethos as, you know, as integrative medicine. It's not my charge. People did wonderful things with the prenatal and the diabetes. And so just want to shout out that hopefully we can get back to that because I think that's just so invaluable. And then upstate, I already referenced the OMM, osteopathic clinic. And then I know there's integrative medicine consults returning. And then we do have CAM Smart Phrases and Epic. I think a lot of the folks in the downtown campus are familiar, but I think some of the Harlem folks know, and I know these things percolate out. There's somewhere around 100 CAM Smart Phrases, mostly organized around supplements. Some of them need updated, but recently we have done some updating, and we're going to commit to continuing to do that. Okay, it's time, bud. Time to go. In terms of research, we recently just finished a yoga and acupuncture pilot study. I mean, recently, it seems regular. Okay. I say recently, it was really March 2020, where we were stopped by COVID. Then we had a main study, and Dr. Jung did a qualitative study. Other research includes, there was a music therapy that Dr. Schoonover did, I'll unpack later, mindfulness therapy for depression. There's a culinary medicine pilot study, and then I'll talk about the HEAL trial as well. So what I want to do is intermix discussions of these programs along with evidence and just general integrative medicine focus. So the first is to think about chronic pain with a highlight on acupuncture. So the pilot study that we did, what we wanted to do, we knew that acupuncture had evidence in a community setting where you can have people actually sitting in chairs in a room for treatment of various pain ailments, whether it's neck, shoulder, knee osteoarthritis, or chronic lower back pain. And so we wanted to see, well, could we combine this with yoga in a sense? Because one thing, obviously, to provide acupuncture for someone, what if we tied in a more active therapy, i.e. yoga, and how would that do in terms of helping people to get moving? Would the acupuncture help so that they would move more with the yoga? Would the yoga then help with sustainability? This was a pilot study, so it wasn't powered for, you know, efficacy and statements of does it work or does it not work per se. What it was intended to just show is, could we do it? I mean, the answer appears to be that we could. We had to stop early in March 2020, but we did get 94 folks in out of our hope of around 120. It was a 10-week program of therapy for intervention, starting with acupuncture and then bringing in yoga on week 3. And what we found is that the therapies were tolerable providers insofar as they referred to us. And the patients, we had pretty low withdrawals, and they seemed very interested. And then what we also saw on the qualitative study side as well, I'll reference later, was reassuring. The final results also did show some statistically significant improvement on our primary outcome, which is something called the brief pain index. We did it 10 weeks, right when the intervention's done, and at 24 weeks, so sometime after. And in both cases, we saw some statistical significance. So watch for our poster. That was exciting to see. This is the big trial that I know everyone gets bugged by me with the in baskets about please refer. This is called the HEAL Back in Action trial. HEAL is an acronym for federal funding actually to combat opiate abuse and the pain epidemic, funded by Trump actually. So, getting funded by Trump. So this trial, as you can see, is for 65 plus. It's ongoing. It's a multi-center, 4 different sites, 3 on the West Coast and then us on the East Coast here in New York City. And there is a control group. It's usual care. It's called a pragmatic trial. So the idea is that there are some guardrails for what the acupuncturist can do. They can't do, for instance, gua sha or cupping or some of the other things they might do in their offices. It's focused solely on needling. But otherwise, they have actually quite a lot of latitude to treat the chronic back pain as they see fit. Our enrollment goal is 123, and I'm really pleased that we're part of this because of how diverse we are and because we serve an underrepresented patient population. They unintentionally, our partners unintentionally shared with us an email thread, or shared with me an email thread that I was nosy, and I went back, in the dates to see they had considered dropping us after initially we had started the trial together, in the very early stages, because we were fairly different and are fairly different from the way they were going to do things. And NIH said, no, you got to keep them. We want them. That's what we need. We need research. So if that offers any solace, the feds are paying attention to this need. So in the study itself, patients are randomized to either the acupuncture intervention, either a standard one or an enhanced one, or they're randomized to what's called usual care, where they'll continue to see their providers here at IFH. Excuse me. As you guys know, the recruitment is largely via provider referrals. And then we were very lucky to have IT support. And a shout out to them, actually. IT has been so beneficial for us, IT support for this new PPA, which has really been, I think, helpful for everybody. So these are some of our research acupuncturists in terms of pictures, Valentina, Patricia, Dorothy, Dana, and Selena. And they have, what's been interesting as we've gotten to know them is just their ability to jump in to clinical operations here at IFH. They are very practiced research acupuncture at this stage of the game. They did trials at the Bronx and Montefiore, and then they were with us, a lot of them with the prior yoga acupuncture trial, and now here in the HEAL. And they've been invaluable in just knowing how to navigate through, a medical setting with our patients. So the recruitment stats is you all have referred to us from July 2021. So not a very long period of time, 296. So kudos to you guys. That's so great. Really, really fantastic. As probably people know, recruitment, getting your numbers is the bane of research. That's the hardest part. And so it's been great to have so many recruits. Yeah. Our current enrollment is at 58. We're on target more or less to get to 123. And what's been fascinating is our hypothesis was that if we have these referrals, then patients are more likely to enroll in the study. And that's really borne out. If folks are referred, what we're seeing is about a 20% yes rate, where I really am interested, I'm gonna enroll. If we have also sent out postcards, in that setting, it's only about 5%. Which makes sense, right? I don't ever pick up my phone if I don't recognize the phone number. So that's just been validating that your all's endorsement of this study is just so important. Also, what's exciting is we have a significant Spanish-speaking population recruited. I don't have percentages, but it's significant. It's not small. The clinical intervention is taking place at Walton, Harlem, and 17th Street. And so we sort of have this regional piece to it where, you know, if someone's in the Bronx, they're going to go to Walton. If someone's in the Harlem area, they'll go to Harlem and 17th Street downtown. That's not, they don't have to, but generally, of course, patients like that. And so I just want an official thank you. We could not do this research without y'all and your willingness to talk to your patients. I mean, you only have, you know, 17 different BPAs to respond to. And so I appreciate you thinking about one of them because it's you know, tricky to do all this work that we do. So thank you so much. Also, I really need to thank the admin and the medical directors, nursing admin, administration at Walton, Harlem, and 17th Street, of course, the staff as well, for being so welcoming to the research acupuncturists and to just help us make this happen. So thank you so much. So let's talk about evidence for a sec. So my colleague Arya Nielsen has been working through a sponsorship of the consortium, of the academic consortium of integrative medicine and health. And what they did in 2018, and then with an update in 2021, is put together a white paper on, the way they framed it here is non-pharmacologic therapies, because they weren't really interested in whether it was integrative or not. They were just interested in what works, and they were going to look at things that weren't pharmaceuticals. And so this is a really valuable white paper document. If you're interested, happy to disseminate it. And I'll be quoting from that. Another landmark publication that I know the residents probably get tired of me mentioning is that the American College of Physicians, which is in no way an integrative organization, put together through the author Kasim their guidelines on what they think should be done for acute, subacute, and chronic low back pain. And this really highlighted acupuncture, mindfulness, basically non-pharmaceutical approaches for, particularly for chronic lower back pain. And then recently, Arya Nielsen became involved with an acupuncture intervention for acute pain in the ER. The idea that if we can get acupuncture or integrative medicine into acute settings, you can really undercut the feel or need, the apparent, you know, what you feel like is a need for opiates. And if we don't start opiates, then often we have much less risk. So if you look at through this white paper, there really is good evidence for treatment of acute pain with acupuncture. So there's evidence for post-surgical pain. There's evidence in the emergency department setting for low back, neck, abdominal pain, migraines as well. All of these can respond to acupuncture in different ways. There is sort of an adage from the integrative modalities, particularly acupuncture, is when things, the longer things have set in, an illness, an ailment, typically the longer it takes to unravel. And so there is something to be said for getting to acute pain with something like acupuncture. Oftentimes you can unravel it a little more quickly if there's evidence for it. It's also worth noting that for post-surgical pain, there is evidence for massage therapy. There's evidence in the pediatric population for mindfulness-based stress relief, you know, which is a sort of standardized mindfulness approach. There's also evidence for hypnosis and minor procedures. There's really interesting evidence in guided imagery and surgery and blood loss that it appears to be correlated with less blood loss, which is sort of boggling. For chronic pain, I mean, this is where, again, acupuncture sort of shines. There's evidence for chronic pain treatment with acupuncture for chronic lower back pain, chronic neck, chronic shoulder pain, and knee osteoarthritis in particular. It's also been shown to be helpful for cancer pain, which could be understood as acute or more chronic or subacute. Massage therapy again, and mindfulness-based stress relief is also something to think about for cancer pain. A lot of us are aware that acupuncture can be helpful as prevention of migraine. And then therapeutic massage can be helpful for neck pain and chronic lower back pain. And Kasim's publication also pointed out that spinal manipulation, which is a term for, you know, chiropractor work, can be good for lower back pain as well. And MBSR and cognitive behavioral therapy, you know, is it integrative, is it not? But it's non-pharmacologically important, just cost effective for this chronic lower back pain. Dr. Jung, what she did in her development is took our GAP yoga and did a qualitative study on it in conjunction with our former fellow, Dr. Bandiwad, and former resident, Dr. Rai, and some other colleagues. And it was a companion to the pilot study, and it was really interesting. Anecdotally, what the acupuncturists would report back to us is, generally people felt the acupuncture was valuable, and the acupuncture and the yoga was valuable, and they generally saw improvements. But it was nice to see, as I said, we do have decent looking evidence from the BPI changes, and also Dr. Jung's work also helped then unpack, well, what themes sort of came up. And so one of them was this idea of transformative engagement with themselves as they're working through this. And I think that's something that we can see from time to time in primary care. I think it's easy to feel frustrated in primary care too, because there's a lot of not transformative engagement that we see. In a sense, it's why we talk about motivational interviewing. How do we help people change? How do we help them be different, be better? And so that was at least one theme that emerged here. Also, they identified just how important their therapeutic relationship with acupuncturists and yoga providers were. And this was sort of gratifying for me to see too. What I've seen over the years in terms of working with complementary integrative health colleagues is obviously the modalities are different, and there are some significant cultural differences and paradigm differences, but what really persists is therapeutic relationship. Is you don't have healing, no matter what the type, if you don't have a therapeutic relationship. And so that was gratifying to see, and also just to see that obviously the yoga providers and the acupuncturists valued that as well. And then the third thing, which we had hoped, we didn't have, this was in theory a group setting, but because of pragmatics, it didn't work out like large groups. It was really no more than 2 or even 3. But nonetheless, even with that, there was some relationship among the participants in the yoga or in the acupuncture, and they commented on that as well, which was just a reminder that group work can be really helpful with chronic pain. I mean, I think one of the most difficult things with chronic pain can be the lack of hope, and I think that's where sometimes being, having these different options, finding things that resonate with people, and looking for opportunities for group work can be really valuable. All right, so access, right? I mean, in a sense, I would be surprised if any of this is unclear to you. I mean, this is feels sort of obvious, but it's worth unpacking. It is covered. I mean, you guys probably know it is covered by Medicaid sometimes, covered by private insurance. But I think the best way to describe it is under coverage, because you have to start asking questions about, well, okay, so it's covered. So United Healthcare, let's say, covers acupuncture, but how much are they paying the acupuncturist per session? One acupuncturist years ago told me, yeah, they pay me $7 per session, right? Which is not sustainable. I don't know. And so don't quote me on that. That was just something I remember, but it's just illustrative of some of the same things we struggle with as medical providers. How do we, pay overhead if the reimbursement is not particularly high? Medicare has stated in 2020 that they are going to cover acupuncture. The study we're doing right now is supposed to help inform them, although it turns out the NIH and CMS don't talk a lot, or at least don't coordinate a lot. So they're committed, CMS is committed acupuncture as a benefit, but it's really unclear the specifics. And there's some real obstacles. The laws defining who can bill as a Medicaid provider were built in 1967 or somewhere around there. And there weren't a lot of acupuncturists around at that time. So acupuncturists don't really fall under any ability yet to bill Medicare. So there's some significant obstacles that have to be reckoned with. In the same way, we had an acupuncture fellowship where acupuncturists did their work at Beth Israel before the move that was led by Dr. Aria Nielsen. And we wanted to bring that to the Mount Sinai main hospital, or we wanted to see if we could, but they don't have a credentialing process in place for licensed acupuncturists inside the hospital. So that was an obstacle. And so we haven't moved on that, but we want to try to revisit it. I do think there are cultural issues. I think there's ways in which medical providers sometimes don't think it's useful or useful enough for acupuncture and integrative methods in general. I see there's something in the chat. Nice, thanks, Goldie. Goldie just pointed out, highlighting the importance of provider-patient relationship and how important that's been in psychotherapy. I also think patients actually across socioeconomic strata may not think of integrative health as essential healthcare. And sometimes I do think quality of life things sometimes get almost set aside as well. yeah, I'd like to feel better, but really that's not essential. I don't think we say that out loud as people, but sometimes that happens. And I have peers who I think feel that, yeah, integrative medicine, that's interesting, but I don't see it as essential. I don't see it as central to my healthcare. Certainly too, licensed acupuncturists may not be more comfortable or may not be comfortable in more medical settings or with sicker patients, which is why actually they had designed this fellowship in the hospital setting, because acupuncturists wanted to see sick patients and they wanted to get that experience. Our acupuncture students here at IFH are interested because they want to see patients in this setting. And certainly demand. I mean, what we've seen at the demand for acupuncture, particularly as it's become more normalized, way outstrips supply. We have a waiting list of probably 100, 120 folks for the acupuncture clinical operations side. So I want to highlight that we partner with the Pacific College of Health Sciences. Dorothy Wong is my counterpart, who is the acupuncture professor who leads the charge. And we've been doing this since 2015. We started over at Union Square, and then we're able to bring it over to 17th Street. We did, of course, have a stoppage during COVID, but we are back. And we ran a report. It was really fun to see that they've done 1,531 visits over those, 7 years, and 272 patients seen. They usually see any one patient for 8 to 10 sessions. So really just, it's been great to have them on site. It's at no cost to the patients. And our biggest issue is just we don't have enough of them. There's a heavy demand. We have a long wait list. We're looking for more resources. I already called out Dr. Santa Ana and mentioned Dr. Jung, and then have been bugging Dr. Akshinas at Harlem, because it does look like there could be some opportunity for Pacific College to staff at Harlem too. So we will look at that and see if we can do that. So let's move away from chronic pain and evidence and move to mental illness. Where did my thing go? There we go. Oops. Okay, so let's talk about a patient that presumably would be familiar. A 66-year-old woman, her name's Mary. Do we have any patients named Mary? No, I'm just kidding. My sons think the name Bob is really exotic, because me being from the Midwest, they think that's exotic. So 66-year-old female, hypertension, osteoarthritis of her left knee, long-standing major depression. She's not suicidal. Her PHQ-9 is 12, right? It's sort of this, well, I'm not where I want to be, but I'm not, it's not an extreme or an acute situation. She's seeing a therapist who does CBT and had some mild success with sertraline, but didn't like how it made her feel, and so she stopped it. Had a little bit of the sexual side effects, that kind of thing. Just felt a little blunted. So her blood pressure is at goal. She's on her HCTZ at 25 and taking that fine, takes some ibuprofen from time to time, but she's just not where she wants to be. So she wants to talk about, well, what can I do instead of the sertraline in addition to my CBT to help with my depression? So the first thing or not necessarily the first thing, but a supplement that is worth knowing is the St. John's wort. And I think probably everyone here in the audience has heard of it in one way or another. It's been used historically in the herbal traditions for a long time, and is probably one of the most well-studied dietary supplements out there. Ginkgo and St. John's wort really have just tons of studies, and we looked a lot for major depressive disorder. It's a botanical, meaning it's a plant, and so the part of the plant that we're talking about is the aerial parts, the leaves, the stems, the flowers. It's not from the root, for instance. The mechanism of action is varied. It's varied in part because with an herb, it's processed less, let's say, than a pharmaceutical. And so invariably you're getting multiple compounds that are probably active. And so we don't know exactly what the specific compound or compounds is that accounts for its effects. There's some serotonergic mechanisms. There is some monoamergic reuptake inhibition, but it's not an MAOI. You don't have to worry about diet restrictions. There's effects on GABA and glutamate, and there's other mechanisms. And it looks like, so when you look at the research and when you ask about processing of botanicals and dietary supplements, you have to ask yourself, well, what kind of extract are we talking about? Because we're not talking about you take the flowers and you put them somewhere and you dry them and you put them in a capsule. It's not that. This is a process to a greater degree so that it's an extract. And so it's commonly studied as standardized as its hypericin content. You can see very low or hyperifin. And the range appears to be 500 to 1200 milligrams to give you a sense of the dosage range. I'll get more specific in a sec. And the evidence is pretty good. It hasn't been reviewed so recently, but there hasn't been a lot of new studies. and it was found as being superior to placebo for treatment of major depression, mild to moderate. And I think you can feel comfortable with that. I think the evidence is pretty solid on that regard. Mild to moderate major depression, St. John's wort, I think you can think of it as the potency being akin to an SSRI. And there have been a couple of head-to-heads, I think, against sertraline actually, where it was found to be non-inferior or typical outcomes. And as I said, there are different extracts in the studies, but I'm going to push us to one particular one, either this extract WS 5570, and I'll give you an example in a sec. And we already talked about the treatment dose. The one thing that it also did show in terms of possible advantages, it did seem to show less dropouts, less adverse effects. And so it's not like I can clearly say, oh, it's better tolerated than SSRIs per se. I just think it's, again, an option. If someone like our patient Mary is like, look, I'm up for a pill, but I don't want to take sertraline anymore, the St. John's wort may actually be more tolerable for her. And so it could be something that could be done. And I would, you want to use it in the same way you would do an SSRI, where you'd start at a lower dose, around 500 milligrams, and you see how she is in a week or two, and then you can go up on it. And I would have her back in the week time, like you would with an SSRI. And also, it seems pretty well tolerated in the elder population, like the SSRIs. So a couple of products, Nature's Way, as the residents know, is something that I'll use a lot. They're a very reputable supplement maker, botanical maker, and they have a good product for $10 a month. Standard Process MediHerb is another one. And so in that respect, there's some things on the market that are affordable, right? These aren't going to be covered, at least typically, by insurance. And so that is that is an access issue always that has to be addressed. So the one piece, and this of course is what comes up on the boards all the time appropriately, is that, this herb drug interaction is not nothing. This is a real big deal. It has significant cytochrome P450 3A4 engagement where it induces it typically, right? And so this came to fore when we had some pretty well documented case studies of people on donor kidneys, transplant kidneys, on their cyclosporin, I think it has an E, and all of a sudden their cyclosporin levels tanked and went very low, and they lost the kidneys because of the St. John's wort. And so it is really an herb that you don't want to be reaching for if a patient's on a lot of polypharmacy on meds that interact. And these are most of the common meds that interact. There are a few others, but these are the common ones.
Dr. Teets, we have a question.
Yeah. Oh, yeah. Thanks.
From Kat. Is St. John's wort safe in pregnancy and breastfeeding?
It's a good question. I don't think it's been studied well enough. And so what I would say is I would not do it in pregnancy and breastfeeding. I would stick with what we know is safe, like the Zoloft. So in that sense, if something has to be used, so I would avoid it. All right, let me go back. And thanks, Angelica, just keep bugging me there. So in general, St. John's wort, as I said, is pretty well tolerated. It is a little bit of a weak photosensitizer. So just in the summer months, people need to be careful, or if they're if they travel. The side effects as you started are typical of the SSRIs. It may be better tolerated, and you would want to be careful with, in bipolar disorder. I wouldn't give it as a single agent in a bipolar, just as I wouldn't give an SSRI. And I wouldn't given it with an SSRI. It's not clear that there's a big risk of serotonergic syndrome, but sort of philosophically, it does similar things, and there is that risk. Here down the bottom is the smart phrase. This is available systemically. It's not like you have to go looking for it. It should be there, available to anyone in the IFH system, CAM St. John's wort. And so the bottom line, I think, for St. John's wort, it is a viable option for patients who may not tolerate SSRIs, but they need to have not a lot of large pharmacy burden. And it does interact with OCPs. The World Health Organization has said it's probably okay to do St. John's wort, but I generally makes me nervous. So I would probably not have it on a woman who has on OCPs. There's a question about, can you address what makes a good product? Is it USP verification? I wish. The United States Pharmacopoeia does do verification of good housekeeping practices. So they'll go in a factory of supplements and say, okay, they're doing the right stuff. This is a good factory. That's what the USP would do. So that's a quality measure. Unfortunately, that's a cost that the supplement makers have to incur. And so they often don't have that happen. So I will highlight that. Actually, what I use the most, honestly, is consumerlab.com, which doesn't look at the factories per se, but looks at the products. And so I'll highlight that in a little bit, because that's going to come up. So thanks for asking. It's a good question. The other thing you should be mindful of with depression treatment is, obviously there's things that are non-pill, that don't have to be ingested. I mean, exercise. This got a lot of press in 2016 with Kavan put this meta-analysis together. It's a little messy because the aerobic and the non-aerobic are all lumped together. Some were on medication, others weren't, but it did have a moderate to large effect. And we don't know quite what the dose is, but this is where I think, you talk with a patient, you see what they're up for, anything's going to be better than nothing. And of course, we also recognize that motivation is tricky and depression. And so that's probably going to be the hardest part. It's just getting them to start. There is some moderate quality evidence for mindfulness of different types. There's certainly evidence too for music therapy, dance therapy, and then some possible evidence for electroacupuncture or acupuncture in general. Interestingly, I know the acupuncture students at 17th Street have a grief pattern. God, I'm really running behind. Okay, and so cutting myself off. And then St. John's Wort we talked about. If she's anxious, go ahead.
Question.
Yeah.
Is there any evidence of acupuncture for obesity?
Good question. I don't know. I don't know if it's been studied for that. I like the idea in the sense that I feel like sometimes obesity is an issue of inertia, where if someone's not in the right space physiologically, it can be hard to lose weight. And so I would, if people are up for it, I would say, it could be helpful, but I don't know the research on that. There is, interestingly, I wanted to bring up, lavender oil can be ingested, and generally lavender oil is a safe essential oil to ingest. And there have been 3 to 5 studies that have been done, all in Germany, that did find it to be helpful for anxiety. And you take it like you might buspirone, thinking about an anxiety med, where you're taking it every day, not a PRN. The safety profile is good. There was a small study that found it non-inferior to lorazepam, interestingly. And what's also nice is not sedating. And so you can make the argument that it would be helpful for the elders, where we often don't have a lot of options for anxiety. Nature's Way, again, is a brand that is picked up on this Silexin product. Silexin is what it's called in Germany, I think. And so they sell it as calm aid. And so I think that would be a viable option for Mary if she wanted to try it separately from the St. John's Wort. I want to highlight Dr. Schoonover's efforts. She did a virtual music therapy. So this is sort of through Zoom group work with, and Susan Rubin as well, where they looked at moderate severe substance use disorders. It was 8 weekly music therapy sessions led by the music therapist. They're finished with the study and looking at analysis, and suggested through the 6 participants they recruited that it's feasible and acceptable. And so that's promising. That would be something to build on. Dr. Jung also did a mindfulness therapy pilot looking at depression, along with our colleagues Chelsea Ricord, Nushin Javadi, a former fellow Annalisa Germain, and you can see the others here at IFH, where they looked at an 8-week virtual mindfulness-based intervention, again, a group setting on Zoom, where they did 120 minutes for each session. And they got 49 patients enrolled, 63% attendance, so not bad. It did see some improvement on GAD-7s and PHQ-9. Some quotes from participants. I highlighted what I just thought was interesting, because this was a mixed method study, so there was qualitative piece, giving myself a lot of self-compassion. Here's another one talking about being able to focus on breath work and helping with the physical symptoms, I think is critical. I enjoyed I wasn't alone, even though it was Zoom, they still felt that groupness, which was great, and being together. So it was interesting, even on Zoom, people still felt the togetherness. All right, let's talk about chronic disease. So let's talk about John. He has known CAD. He's had his cabbage. He's on standard of care meds, but he still has triglycerides at 300 and doesn't have any depression. And the question is, should I take fish oils? And then the question for us is this elevated triglycerides a problem? And the answer is, we're not sure. We think it is. It does have some correlation with increased risk in the context of CAD, in the context of diabetes. And so what should we do? Well, there was a study, so I'll take a step back. So obviously I'm foreshadowing that fish oils can be helpful. A lot of you know that fish oils are the predominant source and certainly the most studied source of omega-3 fatty acids. And so there were a flurry of studies that suggested maybe it could prevent sudden cardiac death and secondary prevention. And a ton of stuff looked in, and finally a meta-analysis done in 2012 was like, it's unclear that it's helpful for secondary prevention in terms of cardiovascular benefits. So what we sort of landed with for a while is we know omega-3s are essential. We know we don't eat them, or Americans don't typically eat them. And we have epidemiological studies that show that it improves when you eat fish, but then you have this meta-analysis. So AHA, the American Heart Association, still recommended eating fish. And then BAT in 2019, this was a very large, multi-center, multi-country trial, very well-designed trial, took icosapent ethyl, which is essentially EPA only. So fish oil is usually EPA and DHA together at a 3:2 ratio in fish. This is just the EPA. And they got 8,000 patients. Basically, the patients had to have elevated triglycerides at 200. They had to be 45 and older with CAD, so a secondary prevention, or a 50 and older with diabetes or some other cardiovascular risk factors. So, sort of that nebulous primary prevention, but increased risk. They couldn't have heart failure or severe heart failure, and you can see the exclusions, and they couldn't have been taking fish oil. And so they gave them 2 grams twice a day of this Vascepa. Now, Vascepa funded this study. And so this is sort of your typical model that we see in the pharmaceutical world too. The primary outcome then was this composite measure of ischemic events and cardiovascular death. And they found success. So this is high dose EPA, high dose fish oil, where you had patients who had a median LDL at baseline of 75. I mean, these people have an LDL that's appropriate, and yet they still were able to show a decreased hazard ratio, a decreased cardiovascular death from the folks on the fish oil, with a number needed to treat of 21. So it's a pretty low number. And the adverse effects were very minimal. There was this was interesting, a low percentage of AFib, but a little bit higher, statistically significant higher AFib presence in the fish oil group than placebo. The authors didn't really have anything concerning to say about it. I don't know what a mechanism would be to cause it. So I don't think it's causal. I think it's just coincidence, but that's the one thing that was different between the two. Otherwise, yes, a little teeny bit more of bleeding in the Vascepa, that is high dose fish oil, but no significant bleeds, no GI bleeds, no head bleeds. This was interesting, and why I want to get to a question about good products. So the authors made sure to say the results of this current trial should not be generalized. In particular, no dietary supplements, because they are variable and unregulated and have not been shown to have clinical benefit. Now, that's a political statement, it's technically a scientific statement, but that's more political than anything else. And this is one of the obstacles to integrative medicine too, that I think we'll see is a little bit of backlash, where you'll see in research, you'll see in guidelines, them make reference to, well, no integrative because it's not regulated the same way. It's like, well, we can still be smart about it. So let's talk about Vascepa and access. Remember, the study was funded by Vascepa. So if you want to buy Vascepa out of pocket from our friends who funded the study, it's $300. Not bad, $300 a month, right? So $3,600 a year, very expensive. You can get the same equivalent processed icosapent ethyl capsules from Carlson's over the counter at $30 a month. So is that $300 anything to do with the cost of the fish oil? No. So, and not all insurances cover it. A Medicare patient of mine commented when I put him on Vascepa as a trial, I said, see what it costs. He said, yeah, they'll cover it, but I still have to pay $185 a month. So that's just not sustainable. So what I do in those scenarios and what I'm comfortable is I go to consumerlab.com, which takes products off the shelf. And they looked at the Carlson's. Carlson's has a good reputation. And these are the supplements that are basically matched to Vascepa. And Nordic Naturals is another brand that usually does a good job and for fish oil, and that probably they would have an equivalent as well. I just didn't look for it. Carlson's a little cheaper. So yeah, I hear you, Bat, but if my patients can't get the Vascepa, I'm still going to move to this. And everyone has to make their decision about that. Yes, they're not regulated as tightly, but I will say the fish oil industry is pretty oligopolized. It does have, meaning there's not a lot of sources, and it is pretty easy to clean them. And generally what Consumer Lab shows is most of the fish oils on the market are clean and safe. I'm going to skip this just for time, other than to say, we don't know. I mean, yes, eat fish, but is that going to provide what John needs? Probably not. And here's some of your typical omega-3 sources: tuna, salmon, anchovies. There's others, Atlantic mackerel, sardines. You can get vegetarian sources, but the problem is they haven't been studied. So, and they are different. They're not the same compound. So there may be some differences there in terms of benefits. There's a question. Dr. Gale asked about vitamins. So my thoughts about vitamins as opposed to healthy, balanced diet. I'm very much in favor of healthy and balanced diet winning over vitamins. Any vitamin has to be, is relatively expensive to produce. So what they do is they pick the cheapest forms of the various vitamins. And so I'm permissive if patients want to take a multivitamin, but I wouldn't see it as a substitute for something like the Mediterranean diet. That was a great lead-in, by the way, Dr. Gale, thank you. And so to talk about the Mediterranean diet or the anti-inflammatory diet. It was first identified in Lyon a long time ago, relatively, and then there was this question about concerns of the non-intervention arm in this PREDIMED study, and there was some concerns of validity, but then there were many others then that showed that that's valid. There was a review then in 2018 by Salah Salvador looking at cardiovascular incidence, stroke, and heart failure, and showing that it helps prevent significantly with, again, these hazard ratios that don't cross 1. And so a diet that really provides prevention in cardiovascular contexts. The components, go ahead.
There's one other question. You might get into this with in your future slides, but there's a question about, is there evidence?
Yeah.
Flax seeds, walnuts, other plant-based omegas.
Yeah, and so the answer in Sung is, Dr. Mann, is no. It's just, and this is still our model of money. You don't have as much money from the vegetarian sources, frankly, is my read on it. And so no, there's nowhere near as much studies on omega-3 fatty acids from a vegetarian source, which is alpha-linolenic acid. So unfortunately. So the components of the Mediterranean diet: olive oil is the main source of fat, high intake of fiber, low to moderate amount of animal foods, and wide in moderation with meals. Has been then extrapolated to an anti-inflammatory diet so that we can think about this in other traditions. And then the mechanisms of protection to help us sort of sift through this. The high fiber foods, we know that lowers the amount of calories that are coming in. It triggers satiety earlier, decreases cholesterol. Less animal protein favors less saturated fat, and that's going to have less oxidative stress and less inflammation. Nuts, fruits, vegetables, all of those have antioxidants and anti-inflammatory components like the polyphenols. And then to your question, Dr. Gale, it's rich in vitamins E and C, magnesium and potassium, but it's not like you can substitute. So vitamin E is a great example. Vitamin E on the market is synthetic alpha tocopherol, which is synthetic, number one, and number two is one of 8 different vitamin E's out there. So if you're having an avocado in your Mediterranean diet, which is fair, you're going to get multiple vitamin E's. If you take your multivite, you're getting a synthetic version of alpha tocopherol, which is just 1 of 8. So this is where, again, permissive with, multivites, but not the same. And then a beneficial effect on gut health. There's actually this interesting, bench science where short chain fatty acids, which go up with a better diet, decreases the liver synthesis, neogenesis of glucose and cholesterol. Decreased urinary TMAO, also somehow then speaks back to not asking the macrophages to accumulate the cholesterol. I don't understand this stuff well enough, but wanted to share that there is then this interaction and engagement with the gut. So extrapolating to our patients, regardless of their food tradition, then we all need more fiber. I mean, we know this, and I think the trick is going to be, how do we implement it? How do we help patients get there? Avoiding the processed carbs and sweets. Use olive oil when possible. Canola oil would be a okay choice, but really ideally avoid the cottonseed oil, the corn oil, and the soybean oils. Those are very novel and have significant amounts of these omega-6 fatty acids that are arguably pro-inflammatory. Avoid the trans fats, which we know about, and then get your omega-3s and not so many animal proteins. And so it sounds simple, but it requires some investment in cooking, and it requires, culinary or nutritional literacy, which brings us to, well, what can we do? And one thing is my fellow Dr. Kablawi, along with Dr. Carr and Dr. Walter, are looking at, well, what would it look like if we did culinary medicine for our patients? So they're going to look at recruiting a very small group, less than 10, for some teaching to see, well, what would it look like if we did teaching remotely, and how could we then look at outcomes? So something to be watching out for. All right, and this is the last section. I know I'm really very low on time. So let's talk about probiotics. Let's see, there's another question. Yeah, 4 minutes. Talk about probiotics. We have, LG, who has COPD. He doesn't have COVID, but he has an exacerbation. Doesn't need to be hospitalized, but we put him on Z-Pak and prednisone. And so the question is, do we need to add in the probiotics? And does it work? And I think most people know that it does. The probiotics most researched for this is Saccharomyces and Lactobacillus. There's a really large systematic review looking at this, showing that the number needed to treat is only 13, and that the safety risk is really good. There was also an interesting study done at Weill Cornell, where if they gave Saccharomyces, which is what's on formulary at Mount Sinai, to patients with all comers who got antibiotics in the hospital, anyone who had one risk factor or more for C. diff had a cost-effective benefit. So anyone over the age of 65 with antibiotics would qualify. The typical dose, 10 to 20 billion. Here's our CAM smart phrase, very long, I apologize, but of course, once you get to the right stem, you can choose it. And Florastor is what I'll often reach for, not covered by insurance necessarily, but is on the formulary at Mount Sinai, Maine. There is some evidence for probiotics in IBS, but it's not as strong. Align has some evidence, and that's what the GI docs, sometimes you'll see them recommend. And then in terms of diet, people have talked about the FODMAPs diet, not easy. There is some evidence for that. Less evidence for the elimination diet is we'll often do it here, but sometimes anecdotally I'll find help. And so there is that for you if you want. And I'm hurrying through because I just want to get to our summary, and really just to say, look, partly I wanted to showcase, what we're doing, but I also wanted just to identify that we are an integrative institution, and that's us. A celebration of what it is we do, because certainly your all's efforts have been part of this. And I do think strongly that an integrative approach offers important ways to address quality of life. It would be interesting to think about all this work and then think about the VA's approach and whether we could use their paradigm of whole health. And so future possibilities could be looking at that. I would love to increase acupuncture availability. There are therapeutic massage students at Pacific College, and I just need to make some phone calls. Maybe we can get them to come. Looking at expansion of our services and other services into the hospital. There's music therapy there. There's occasional therapeutic massage to the palliative department, but it's limited. We do want to continue to bolster our EPIC smart phrases so that the EPIC can be a resource for you all, looking at these conditions that I highlighted and continue our research. So that's it. I was a little bit too fast at the end, but I really appreciate you guys' questions. And I'm certainly okay to hang out for a few questions if there's any more.
Thanks, Ray. This is great stuff.
Thanks.
And we really appreciate your leadership in this area, because it takes some real leadership to get things going. And I was just amazed at how many people are involved in this work, which is just a testament to your ability to spread this and to get people excited and enthusiastic about it. So are there any last minute questions? Otherwise, we'll say thank you very much. And we look forward to continuing this work going forward and expanding it.
Yeah,
Thanks.
exactly. Thanks, everyone. Thanks for listening.
Great work, Ray. Thank you.
Thanks.